and welcome to ACR Journals on Air podcast. I'm your host, Vicky Shamagam. I'm often asked how the articles we profile on ACR Journals on Air are chosen. The editors of the 3 ACR journals usually propose articles to our producer, Joe Rojas. But we also greatly appreciate it when our listeners and readers of the journals suggest an article that has piqued their interest. And today's article is a twofer because it was pitched by the editors and several of our listeners. In fact, one listener said it was vital to profile this article because this manuscript gets to the ever-elusive holy grail in rheumatology prevention. And this research is not just another study, it's a big step forward in our understanding of autoimmune disease prevention. The manuscript we will discuss today is Vitamin D and Marine N3 fatty acids for autoimmune disease prevention, outcomes 2 years after completion of a double-blind, placebo-controlled trial. It was published in Arthritis and Rheumatology, and a link to the manuscript and disclosures are in our show notes from today. I'm thrilled to be joined by the first author and a highly respected physician scientist, Dr. Karen Kostenbader. Dr. Kostenbader is Professor of Medicine and the Michael E. Weinblatt Distinguished Chair in Clinical Rheumatology at Harvard Medical School and Director of the Brigham and Women's Lupus Program. She specializes in the epidemiology and management of systemic lupus erythematosus and has been a leader in many prominent epidemiology studies investigating autoimmune diseases and their co-associated comorbidities. Welcome to the show, Karen.
Thank you very much, Vicky. It's very nice to be with you. And thank you for those nice words about our work. It's always gratifying to hear that people are actually reading papers and appreciating them and that they're having some impact. Because, of course, I think that this study was very exciting, but I'm glad that others do too. Thank you.
Yeah, others do too. So I wanted to start our discussion today with a little bit of epidemiology background about autoimmune diseases. Combined, autoimmune diseases are very common, affecting nearly 10% of the population. Indeed, estimates suggest about 23.5 million Americans are living with autoimmune diseases, and that's probably an underestimate. To place that in context for our listeners, at the end of 2021, 1.2 million Americans were living with HIV. So autoimmune diseases significantly more common than some of the diseases that we've invested a lot of funding and research for. You start your manuscript with a lovely introduction to the epidemiology of autoimmune diseases and the scope of the problem. And I wondered whether you could share some of that background with our listeners.
Well, thank you. Yeah, I totally agree. I think you've touched on some of the figures that autoimmune diseases as a totality, as you know, incur really high burdens of disease and costs and seem to be on the rise. A lot of them occur in women. Many of these conditions have female predominance, and we don't understand that. And a lot of them, the incidence of autoimmune diseases increases with age. But there seems to be different autoimmune diseases in younger people and older people. As a totality, there are probably over 100 different autoimmune diseases, and I learned about many of them in the course of this study and validating the outcomes. They do have many shared underlying pathogenic mechanisms, include shared genetic predispositions and then probably environmental conditions and exposures as well. And I've actually been fascinated by autoimmune diseases since medical school, really, when I first heard about them. And I heard about the idea of the immune system turning on itself and recognizing self. And I thought, well, that is just weird and fascinating. And it seems like we should be able to figure out why that would happen. And of course, many years later, we have many more clues. And I think in this study, the VITAL trial that we're going to talk about, we looked at all of the autoimmune diseases as one big entity. And when you do that, you're very right. The statistics are really staggering that there are so many people suffering from autoimmune diseases, as you mentioned, in the country and throughout the world.
So that's a great intro. Let's talk a little bit about the data in your manuscript. Your manuscript is based on longitudinal follow-up of people enrolled in the VITAL trial, which was the vitamin D and omega-3 trial investigating the impact of vitamin D and N3 fatty acid supplementation on, among other things, the incidence of autoimmune disease. Before you tell us about the trial, can you tell us a little bit about the why of the VITAL trial? Why was it vital to look at vitamin D and marine-derived long-chain omega-3 fatty acids and their impact on disease? And what's the immunology behind this study?
Good question. So it was a very fortunate opportunity that the VITAL trial was getting organized, and I heard about it right in my neighborhood because both of these supplements, there's reason to believe for both these supplements that they have a lot of effects on the immune systems. And actually, people are taking, there's a lot of hype out there. Lots of Americans and lots of people probably around the world were taking these for many reasons, including, the quote, immune benefits of both vitamin D and omega-3 fatty acids. So vitamin D, there are many, many animal studies, in vitro studies, and some human studies showing that it has many, many effects. Vitamin D is a lipid-soluble vitamin that regulates a wide array of genes involved in inflammation, many of which are involved in inflammation in both the acquired and innate immune responses. There have been studies of the way that it is associated with ecological studies of inflammatory bowel disease and multiple sclerosis and type 1 diabetes, and being more prevalent in northern latitudes where vitamin D is low. And then there were also studies of residential exposure to UV light being associated with decreased Crohn's disease in France. And then in the Nurses' Health study before this, we had looked at plasma 25 hydroxy vitamin D levels as well as residential UV exposure, and both were associated with a lower risk of developing rheumatoid arthritis in the future. So there were clues in humans as well as all the evidence from basic science and animal studies of the effects on the T and B lymphocytes and the macrophages and monocytes and multiple levels for vitamin D. And similarly for omega-3 fatty acids, there is a lot of evidence of how they work to suppress the biosynthesis of inflammatory arachidonic acid-derived eicosanoids, and they upregulate inflammatory transcription factors or transcription factors involved in inflammatory pathways. And then there were some observational studies as well from humans, and Danish prospective cohort showed a lower rheumatoid arthritis risk in those who had a lot of fatty fish intake, and omega-3 fatty acids are primarily from fish, but also from nuts and seeds in the diet. And then their work out of Colorado showed that a higher N3 fatty acid to total lipid proportion in the erythrocyte membrane was associated with a lower prevalence of the autoantibodies involved in development of rheumatoid arthritis, anti-CCP and rheumatoid factor, and a lower progression to inflammatory arthritis in their studies in the SIRA cohorts. So there was abundant evidence from the basic and animal studies. Omega-3 fatty acids also, I should note, have been proven to reduce inflammation and improve outcomes in rheumatoid arthritis and in lupus and a few other conditions among people who have the disease. But they had never been tested. Neither of these supplements have been tested prior to, or the supplementation on the incidence of autoimmune disease occurring over time thereafter, despite the fact that many, many people are taking them for these indications.
Yeah. So tell us, how did you get involved in the VITAL study as the rheumatologist, epidemiologist background?
Yeah, I was in the right place at the right time, I think. I had worked for many years on studies in the Nurses' Health study, looking at risk factors for the development of rheumatoid arthritis and systemic lupus erythematosus in particular, in validating cases. And I'd gotten to know Joanne Manson, who is really just a giant in the field of big randomized trials like this and pragmatic trials, as well as all epidemiology. And she's the chief of preventive medicine here at the Brigham Women's Hospital. And I heard about VITAL, and she approached me at the same time I approached her as they were just organizing the study. And she and Julie Buring, who also is another giant, I think I learned epidemiology in medical school from Julie, were organizing this big trial of over 25,000 adults across the country to investigate vitamin D supplementation and omega-3 supplementation. At that point, they didn't know the doses, and they were thinking of looking at both or examining both for prevention of cancer and cardiovascular disease. Because I said, everyone's taking these for all the myriad different indications, and many people are taking them because they think they may prevent cancer and or cardiovascular disease. So they were just organizing and designing the trial, and they asked me if I would be interested in being involved in writing an ancillary study. So we did, and we got our ancillary R1 funded actually before the trial was about to start, which is perfect, because then we could really follow people from the very beginning of the trial to look at these ancillary outcomes of autoimmune diseases and all autoimmune diseases.
Yeah, no, and I think that makes a huge difference, and so thankful that you were, as you say, in the right place at the right time. I think sometimes things happen for a reason. So tell us about who was enrolled in the VITAL study, and I guess more importantly, who was excluded.
I mean, it was really a tour de force. They know how to do these big pragmatic trials. So they mailed invitations to be involved in the study to millions of Americans. It was men age 50 and older and women age 55 and older who were enrolled, and the targets, because they were looking at cancer and cardiovascular disease in primarily older adults. So that, is not ideal for all autoimmune diseases, but many autoimmune diseases do occur in older adults. Because they were looking at cancer and cardiovascular disease, as you mentioned, they did exclude people if they had a history of cancer or cardiovascular disease. They were not excluded if they had a history of autoimmune disease. So we do have people who had one autoimmune disease or more at baseline. And through these mailings, they had many, many positive responses, believe it or not. And then they screened people and randomized people. And there was a run-in trial to make sure people would be adherent. And over 25,000, so 25,871 people were randomized from communities and residences all across the country. One of the main goals was to include African Americans and, purposely select them. So there were over 20% of the participants were African Americans, which was fantastic to really have a subgroup that's big enough to make sure that we could look at separately. So there were 12,786 men and 13,085 women. And then it was a 2x2 factorial design. So they were first randomized to either getting vitamin D, and that was the final dose decided was 2,000 international units a day, or a placebo pill that looked just like it. And then they were re-randomized into getting the N3 fatty acids, the fish oil supplement, 1 gram a day, or placebo. So everybody got 2 pills, and there were 4 different combinations: 2 active pills, 1 active pill, either one, or 2 placebo pills. So 4 arms of the trial overall. And then everybody was followed for 5.3 years on average. And there were blood samples at baseline on 2/3 of people. And it was really a beautifully conducted trial through the Division of Preventive Medicine that I was lucky enough to be involved in.
And given this was a prevention study, how did you evaluate for incident autoimmune disease in this study? And can you explain which diseases you included?
So, as I said, people with autoimmune disease were not excluded at baseline. So we had a baseline survey and then annual surveys that went out to everyone, and they had a very high adherence rate to the surveys as well, probably because all the research assistants were very good at harassing people and hassling people to get their information back. So people self-reported at baseline all their possible diseases and including autoimmune diseases. And then they self-reported all new doctor diagnoses of autoimmune diseases. We thought that the most common autoimmune diseases in older populations, polymyalgia rheumatica, rheumatoid arthritis, inflammatory bowel disease, psoriasis and psoriatic arthritis, and autoimmune thyroid disease. So we specifically on the questionnaire, you have to kind of jockey for space on the questionnaires that go out. We don't want to overburden people. We asked about those autoimmune diseases, and then we asked them to write in any other doctor diagnosed autoimmune disease. And so, as you can imagine, people wrote in just about everything. And it was a lot of work to confirm all of these diagnoses. We had a team of physicians working on it, but I think I reviewed every single one. And it was continually, people were writing in hepatitis C, and I was saying, no, that's not autoimmune. But then there were reports of all kinds of autoimmune diseases, and that's in the supplement of the first paper, showing, all kinds. There was alopecia and vitiligo and all kinds of things that arose. And we do have a secondary analysis in the paper where we excluded anybody with baseline autoimmune disease of any kind. For the primary analysis, we included any autoimmune disease that wasn't already present at baseline. So we did ask people if they had an autoimmune disease. Then we asked them who diagnosed it and for a medical record release. And then we got the medical records, and we reviewed all the medical records to make sure that they did have a new autoimmune disease. And some of these autoimmune diseases, as you know, have criteria for classification, and some don't. So, and the hardest to confirm was autoimmune thyroid disease. because we had all kinds of criteria, including autoantibodies and things like that, that unfortunately in clinical practice are really not checked. So we had a lot of possible autoimmune thyroid disease. That was our Achilles heel, I think.
Thyroid disease, possibly autoimmune.
Yes, exactly. There were a lot of possibles that really, so we had two analyses that were also pre-specified. One was the confirmed autoimmune diseases and then the confirmed plus possible. And the numbers in the confirmed possible included a lot of those autoimmune thyroid diseases.
Yeah. So I wanted to ask you a little bit about the follow-up period. The study's randomization occurred between November 2011 to March 2014, and then you treated people for 5.3 years after that randomization, followed by continued follow-up and questionnaires and reporting of endpoints for another 2 years, which sounds like a long time. But with autoimmune disease, was it really long enough?
Exactly. So you've got it all right. I think that is an open question, right? We know that autoimmune diseases develop slowly over time. I think we were lucky to have the 7 years follow up. And I think some of our results were surprising to me, and I'd love to dig into the results. For the vitamin D, we really saw that there wasn't any effect. It didn't look like the curves for the different randomized groups diverged at all in the first couple of years. But after that, we started seeing an effect of vitamin D. And that maybe makes biological sense to me, that whatever supplement you're placed on is not going to have an immediate effect, especially if it's really involved in the biology of the developing autoimmune disease. It will take some time, and these diseases develop over time. So seeing the curves diverge after 2 years did make sense to me, versus the omega-3 fatty acid groups actually diverged very quickly. So maybe differing biology there. And then at the end of the randomized period, the 5.3 years, people were invited to continue to be followed, but they could take anything they wanted to. During the trial, obviously, they were only allowed to take the 2 pills they were given in the 4 different combinations, and they were discouraged from taking any, or they were not allowed to take any other vitamin D or fish oil supplements. And then after in the extension period, they were allowed to take whatever, vitamins and supplements they wanted to take. They did report them, but we weren't sure exactly what kind of supplement and what manufacturer's, formulation they were taking or how much at that point. So that was more of a free living observation. And then we saw that the vitamin D effect really quickly dissipated, and the curves went back to, looking like the placebo group, whereas the effect of N3 fatty acids continued and actually reached a little bit more significance. So the timeline and the time course of how these supplements may be involved in decreasing the incidence of autoimmune disease, I think is fascinating in terms of what's going on with the biology as well. And maybe for both of them, there's a little bit different underlying mechanisms.
Yeah, so that's great. So you've jumped kind of forward to the graphics in this paper, and they're actually really great visualization of the data. For our listeners, obviously, this is audio only. So if you're listening and are planning to download this manuscript, do download it in color, because the lines are otherwise pretty tricky to see. But Karen, can you slowly walk us through those graphics? So start with figure 1, which is looking at the cumulative incidence of autoimmune disease in the patients randomized to vitamin D or placebo. What did that show?
Sure. So the overall results for the confirmed incident autoimmune diseases, there were 278 cases in the original 5.3 years of the trial, and the hazard ratio just squeaked in. It was about 0.78, and the upper limit of the confidence interval was about 0.99, and the p-value about 0.45. And so you can see the curves actually up to about 3 years, the placebo and the 2.5 to 3 years, the placebo and the vitamin D groups look indistinguishable. And then the active group does drop in the cumulative incidence of autoimmune diseases. And then similarly for the confirmed and probable cases, we had 457 probable cases. And here the hazard ratio was about 0.85, and it wasn't significant, but looks very similar that about 2.5 to 3 years, the curves start to diverge.
And if we jump back to table 2, there was one disease where the vitamin D seemed to really make a big difference. Which disease was that?
I think that there were a few diseases that Bear mentioned that I think that the point estimates were lower. I think that there were small sample sizes, so we couldn't really give them shout outs. But when we looked at the top 5 autoimmune diseases that we were thinking about polymyalgia rheumatica, has a ratio of 0.67 and almost significant with a p-value of 0.06 there. And then RA and psoriasis all had lower, and actually inflammatory bowel disease too. So a lot of them had very low confidence intervals, which was very low hazard ratios and confidence intervals. And I think that psoriasis did make it to significance at 0.61 after in our updated analyses with 2 years extension as well.
So next, let's walk through figure 2, which was the omega-3 fatty acid results. What did you see in that analysis?
So for the N3 fatty acids, actually, we also see the curves diverge. For the 278 confirmed incident cases, they diverge around 1.5 years, and the hazard ratio was 0.85, but this was not significant as the confidence interval went up to 1.09. But then when we included all those tricky probable incident autoimmune diseases, actually, then we did reach significance, and the hazard ratio was 0.82. And the p-value of 0.04, and then the curves look even farther apart, and they start to diverge even earlier. So, again, those probable cases flipped it one way or the other, and it did give us more power as well to see a difference. So both supplements, in my opinion, I was as shocked as anyone by the results. I must say that after wading through all of those confirmations of all of those autoimmune diseases over so many years, all that hard work, I was thinking the main results of the VITAL trial for cancer and cardiovascular disease, and even for osteoporosis, were all null. And so I was really pleasantly surprised to see that we had an effect, even though I had convinced myself when I was writing the grant that there was really a lot of really strong science to test these two. I was as excited as anyone when I saw the results.
Yeah. And you did some secondary analysis looking at the 4 groups, because as you mentioned, it was kind of really 4 groups, 2 active supplements, 2 placebos, and the combinations thereof. You show those results over in figure 3. Can you walk us through that graphic?
Yeah, so I think that because it's a 2x2 factorial, it was the strength of that study design is that it allowed us to test both vitamin D and omega-3 in one trial. The weakness is that for the overall results of vitamin D or of fish oil, there's actually another intervention group in there, which could decrease the likelihood of seeing an effect. So when you look at the 2x2 factorial groups, or the 4-arm groups, and especially in color, as you say, I think the figure tells 1,000 words, that compared to the placebo rates and the cumulative incidence, which continues to climb, all 3 of the intervention groups are much lower, both for the confirmed and the confirmed improbable. And they do kind of overlap. And the hazard ratios for the individual groups are down 0.69 and significant, 0.68 and significant, 0.74. So, and then with confirmed improbable, the 457 cases, all of the intervention groups in the initial analysis were significant, which was really exciting. So to about the same extent, 25 to 30% decrease incidence in the individual groups compared to the placebo arm.
And take us back then to the time period for this study, because we know that time waits for no man or woman or clinical trial. And the prodrome for autoimmunity in some diseases is really rather long, as you mentioned. And we know in many autoimmune diseases, certainly autoantibodies are detectable more than 5 years before symptoms or clinical manifestations of disease. So some people presumably entered this trial with a degree of subclinical autoimmunity that then became manifest during the follow-up period. How did you account for that in the analysis?
Right. So that did complicate things. I think probably even more so than for the cancer and cardiovascular disease or other endpoints. As you mentioned, autoimmune diseases do develop slowly over time and then also take time to reach diagnosis. So in the second paper, where we report on the outcomes after 2 years of non-randomized observational follow-up, we had continued to receive reports during this period. People were continuing to give us their medical records, if they had any new incident disease. And for some of those new reports, we found that they actually, we were very conservative, And we always dated the onset of disease to the earliest symptoms in the doctor's report, saying, when someone's seen for their polymyalgia rheumatica or rheumatoid arthritis, symptoms started, 3 months ago, symptoms started 2 years ago. So we dated them back. And so a lot of those cases, unfortunately, their incident date fell back into the randomized time. So we provide updated results with those cases as well, which did change things a little bit, unfortunately, because we had closed out at the end of 5.3 years the case follow-up, but then we continue to accumulate cases that happened after the randomized time and some of which happened during the randomized time. So we have accounted for that.
Yeah. You also did some secondary analysis based on body mass index, and that showed some quite interesting results too. Could you walk us through those?
Right. So they were pre-specified. And there is literature about vitamin D in particular and body mass index. And so we had, despite a wide range of body mass indexes of people in the trial, everyone got the one dose of 2,000 international units of vitamin D. And in VITAL and in other studies and trials, we saw that the increase or the bump in vitamin D levels that was achieved in people of higher body mass index was lower. And to the biological effect on incident autoimmune disease, we also saw that there was a statistical interaction with body mass index, and the people who were at normal or low body mass index had a stronger effect of the vitamin D than those who were in the obese category or above. And I think that makes biological sense. There's some thought about, just the volume of distribution, and it's a fat-soluble vitamin. And actually, I know that Dr. Manson and others are interested in pursuing the interactions of vitamin D and body mass index and vitamin D metabolism, and what is the ideal dose for supplementation based on body weight. So it could be that the 2,000 international units really doesn't do as much, and it didn't do as much for prevention of autoimmune disease in people who were overweight and obese.
That's really interesting. And so maybe weight-based dosing for some of these supplements may make sense. I'm interested also, I think, were able to analyze a little bit based on the people who continued supplements during the observational period and those who didn't. Are you able to share any results from that component of the analysis?
We repeated analysis in the observational period. Then we censored those who reported that they were taking greater than 800 international units of supplemental vitamin D because they were allowed to take anything they could. Then in the observational period, the results were very similar. It was still null. The people who were initially randomized vitamin D and then follow the overall hazard ratio was 0.95 at the end of the now 7.3 years. And then similarly censoring, there were about 22% of people who reported that they were taking N3 fatty acids during the observational period. And here we didn't have a dose, but then the hazard ratio for confirmed autoimmune disease in that group was 0.89. And that was a little bit higher than overall. The confidence interval was 0.73 to 1.08. But the smaller sample size, so I should have said there were 28% of the people reported that they continued to take vitamin D in the observational period, and about 23% were taking N3 fatty acids. And that could have been because they heard about the results of the trial and they were interested in continuing. And so that did muddle it a little bit, or made it a little more difficult to figure out what was going on with the initial randomization if some people were taking it and some people weren't.
Yeah, I agree. And I'm intrigued to get your insights into what this all means for our patients. And in particular, obviously this was a cohort of patients who are in a older age group. We think of prevention in autoimmunity perhaps happening or needing an intervention earlier in life. What does this all mean? And what do we tell our patients? And in particular, how do we respond to that very common question? Is there anything we can do to prevent autoimmune disease either in an individual or in an individual's relatives after there's been an index case?
Well, I love the question, and I know there's tons of interest in prevention of autoimmune disease. I myself am really, really interested in pursuing this, and I talk to my patients about it a lot. I think my patients who have autoimmune disease, I think that both of these supplements, well, as I mentioned at the outset, that vitamin D has been proven in clinical trials to ameliorate outcomes, many different kinds of outcomes and inflammatory biomarkers and tender swollen joint counts and rheumatoid arthritis. And this trial and others have shown that they're very safe supplements, that at least these doses, there were really no safety events at all. So no concerns there. And I do encourage, because everybody's interested in taking supplements and what other things they can take. And I do encourage people, if they're interested in taking supplements and vitamins, to take these doses of vitamin D and omega-3 fatty acids. I think that they're safe. And together in the trial, we calculated the number needed to treat to prevent autoimmune disease. And this is an older population, as you said. And it was about 231 people would have to take them for 5 years. So we'd have to do the math to see if that makes cost effectiveness sense. But I think they're pretty cheap supplements. They're over the counter. And certainly if you develop one of these autoimmune diseases, it can be deadly and very morbid and very costly. So if we can do things to prevent the development of autoimmune disease, I think that's important. And people are interested not just for themselves, they're interested for their family members. And we know family members are at much increased risk of disease. And often I see the family members of my patients, and they're interested in what they can do and what they should do if they have an autoantibody or some early symptom. And it's hard. And I think we're working on biomarkers to predict who will develop an autoimmune disease. And I myself am very interested in repeating this kind of trial in younger individuals with different array of autoimmune diseases. A lot of my work has been in lupus, and there were very few lupus cases confirmed in this older population. So I think I love to talk to you more about this, thinking about repeating this trial or another kind of trial to work on environmental exposures and lifestyle factors that we also know are very important for the development of our autoimmune diseases, lupus and rheumatoid arthritis. In a younger population, it may be at high risk. So there's more to do for sure. And I think we're just cracking the nut. This is the first autoimmune disease big prevention trial of a community population, not necessarily at high risk for this group. These are just people over age 50 or over age 55 out there. And we did prevent, you can say that because it's a trial, it did prevent, a certain number of autoimmune diseases, which is exciting. And maybe we can go on and test other prevention methods and these supplements in a different population.
Yeah, I think it's really enticing and exciting to see this data come through, because we've never gotten really to much prevention before for autoimmunity, and this looks really exciting. So I really appreciate you sharing all of those results. I'm wondering if I can change direction now and ask you a little bit about your career in science, because throughout your career, you've worked on several foundational studies that have helped us understand the epidemiology of autoimmunity and particularly co-occurring autoimmune diseases. So, Karen, I wanted to ask you, what drives you in your scientific career?
Well, that's a big question. That's nice of you to say that. Yeah, as I mentioned at the outset, I think I've been interested in autoimmune diseases since medical schools because they are fascinating diseases. And I think in medical school, to go way back, we heard of a case. We were presented cases and discussing of a young woman with lupus, and digging into my age and the autoimmunity, why the immune system should turn on itself and attack one's own organs just seemed so complex, and the immunology so fascinating and so important that I've really been driven to try to figure out from an epidemiologic perspective why this might happen. And I think even in medical school, we were taught that these are mainly genetic conditions. And certainly there's definitely genetic susceptibility to autoimmunity and to specific autoimmune diseases. And with genome-wide association studies, there are now hundreds of genes that are involved. But I've been really fortunate to be able to work here at the Brigham and at Harvard on the Nurses' Health Study and in the Black Women's Health Study, and using other large populations to try to identify risk factors for the development of rheumatoid arthritis and lupus and other conditions that are associated with these diseases, as you said. And I think the picture really over time has emerged that it's not all genetic, that there are many environmental exposures, and vitamin D intake and fish intake may be one of them. that drive the development. And I think probably people have, the emerging paradigm is you have an underlying genetic susceptibility, but then the exposures during your life, and we've shown that cigarette smoking and obesity and low alcohol intake, and then other diseases like endometriosis and hormone use, then there's silica and pesticides, many different exposures all are associated with an increased risk of developing lupus and rheumatoid arthritis in particular. And we've put these together into risk models now, which I think is the next step in terms of where we're going in predicting autoimmune diseases in people, in a population, or maybe to screen a population for risk of autoimmune disease and then move forward with an intervention. We are just showing that the risk model that we developed in the Nurses' Health study for systemic lupus, including genetics and environmental risk factors. There it had an area under the curve for accuracy of prediction of about 0.76. And in a separate population, we're showing that it has accuracy of about area under the curve of 0.81 and 0.82, which is fantastic because I'm very pleasantly surprised that this bore out. And then we also showed that if we put all the risk factors, or 5 of the risk factors, the kind of the healthy lifestyle behaviors together, and and flipped it the other way, that if you followed healthy lifestyle, you could reduce the risk of developing both rheumatoid arthritis and lupus substantially. The population attributable risk was about 0.47. So, a huge amount of the risk was attributed to just those healthy lifestyle behaviors. So I think that probably my excitement, it conveys why I like this field. I think we're discovering new things about how autoimmune diseases develop and what we can possibly do to prevent them. And I've been able to work with fantastic people and wonderful mentees and continue to dive into the results and formulate new questions. So it's been very rewarding as well. And I hope we make some more breakthroughs.
You've had this amazing good fortune, and you describe it as luck, but I really am not sure that it's luck. I think it's probably partly your personality. But you've been able to partner with many of these really large ongoing studies to evaluate outcomes that perhaps the primary or principal investigators were not thinking of. So, many of these studies were designed to investigate long-term cardiovascular outcomes, and you let them pivot into the autoimmune disease space. Can you share with us and our listeners, how did you get your start? Do you have any advice for investigators with burning research questions on how to engage with epidemiologists running some of these large cohort studies?
That's a big question too. Yeah, I have been very fortunate. I had great mentors, and I think Beth Carlson was one of my first mentors, and Matt Liang, and they introduced me to the Nurses' Health study, and I learned a tremendous amount of epidemiology from the investigators there, and just going to the weekly meetings and hearing the presentation of results and the presentation of grant aims and the discussions around the table. I've learned so much, and I've been able to partner and collaborate with people in the Nurses' Health study. We actually now have a funded study on polymyalgia rheumatica as the women are all getting older in the Nurses' Health study, and then other cohorts as well. And I think that's one of the nicest things about my job as well, collaborations. I collaborate with a lot of different people in different parts of the country and different parts of the world now in their cohorts. In terms of advice for young investigators, I think that there are opportunities out there. There are these big biobanks. There are now working in All of Us, a nationwide NIH-funded big EHR cohort, that there's plenty of opportunity for diving into autoimmune diseases there. And there's the RISE registry through ACR. There are many other big populations that really do lend themselves to studying autoimmune diseases where, as you say, they may have been set up for following other diseases. It is a lot of work to then say that you will come and validate all the cases and get all the cases in the Black Women's Health Study, for example. We partnered with them, but then my colleagues and I, a lot of my mentees and I, had to get all the medical records for the lupus cases and hand validate them. It was worth it because then we could do some great studies of risk factors for lupus in the Black Women's Health Study with them as well.
And I love reading your manuscripts because your work always tells a story. So even when the data takes an unexpected turn, you're able to tell the story of the data. And I think that's the mark of a great scientist, is really letting the science and the data drive the discussion. What tips do you have for our listeners on communicating science?
Oh, well, that was a very nice compliment. I'm sure that my more recent papers were
better written than my earlier papers, and something that you learn as you go along. I think I remember writing my earlier papers, and they were about 900 pages long, including a limitation section that was 4 pages. And I got a lot of helpful feedback along the way about communicating science. But the fun is really digging in and interpreting the data. And having attended all these great epidemiology meetings, I think I've come up with other reasons that, there may be confounding by indication, there may be competing risk of death, there may be other things that you can think about that may explain some of your results, especially when they're not as expected, because there probably is an explanation. It could be that is the science, and you have to think about the biology, but you also have to think about the epidemiologic challenges of power and confounding and other problems that you can come along the way. So I think in terms of advice for people getting started, it is really fun. So don't lose sight of that. I think that working with people who've been doing it for longer and mentors and allowing them to guide you is also really helpful. And then working with younger people, and it's like see one, do one, teach one. And if you can explain it to someone else, then you probably have a very good mastery of it.
Yeah. And are there any mentors along the way who've really been strong guides to you that you'd like to give a shout out to?
Well, Beth Carlson and Matt Liang was my first research mentor and the reason I came to the Brigham. And then I started working more with Beth Carlson as well. And she was fantastic. And she's still around at the Brigham, and she now works mainly as the big PI of studies like All of Us and a big I2B2 project and the Mass General Brigham personalized medicine course. So she's really on all of these big NIH funded studies, but she's still around, and she's been fantastic along the way of instructing me and giving me a lot of freedom as well. She was my mentor, and then she became a very close collaborator for many years. So definitely want to have a shout out to Beth.
Yeah. And some of those huge longitudinal cohorts, particularly All of Us, that's kind of just finally coming to ability to start analyzing and doing a big dive into data, could be really fruitful for autoimmune disease. So
exactly. And we're lucky that for autoimmune disease, we're very lucky that Beth has been instrumental in designing the questionnaires for a lot of these large databases, because we will have the answers to some of the same kind of questions along the way, which is nice.
Yeah, it's great. You also serve on the Medical Scientific Advisory Council for the Lupus Foundation of America and in various roles at the American College of Rheumatology. You're a very active grant reviewer. You're an editor for several journals. I wondered whether volunteering is a little bit like vitamins. It's a vital supplement to sustain a long and healthy life in science. Do you have any advice for our listeners on supplementing their professional careers with volunteer roles?
Oh, that's a nice analogy. I like that. The volunteering vitamin. I think you can volunteer for too many things and you can get overloaded. So thinking about the opportunities that you want to take on sequentially and which ones are most meaningful to you. I think working with the Lupus Foundation of America is extremely meaningful to me. And I really love that time working with the patient volunteers, with the organization, and similarly with the ACR. I think really thinking about funding the next generation, the research opportunities with the ACR has been very meaningful. And you can't do it all at once, so I don't do everything every day, but I really would encourage people to think about it as a vitamin and make those connections. And rheumatology world is pretty small, so making those connections and networking across the country is extremely valuable. When you go to the ACR meeting and you know so many people, it's a great experience. And there's a lot of interchange of ideas and a lot of excitement.
Yeah, it so is. And I love that you're taking that one step further and saying the dose matters. So, there can be too much of a thing. Karen, this has been an excellent discussion. I want to thank you for sharing your stories and tantalizing us with this vision that maybe one day autoimmune diseases could become preventable through vital research. Thank you so much.
Oh, thank you very much for having me. It's been very enjoyable.
So today, I also want to give a massive shout out to our listeners who recommended this manuscript. If you have other suggestions, please feel free to send them our way. The email is podcast@rheumatology.org, or you can corner me at a meeting. I always love to hear what people are reading. Thank you all for listening to this podcast. ACR Journals on Air is a production of the American College of Rheumatology. Please follow @ACRheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts.